mycotic aneurysm. There's infection of a major blood vessel. Due to the infection, it's nothing to do with fungi, as the name suggests. And pneumonia and pancreatitis, kidney or bladder infections, hepatitis also. So you have the multi-drug resistant and extensively drug resistant typhoid fever. In multi-drug resistant typhoid, you have resistance to ampicillin, chloramphenicol, and tricatroprim sulfamethoxazole combination. The H58 strain is the most common MDR typhoid strain and has been found in many parts of Asia, Africa, and Latin America. The extensive drug resistant typhoid is luckily a bit on the lower side. It is resistant to ampicillin, chloramphenicol, trimethoprim sulfamethoxazole combination, and third generation cephalosporin. Earlier, it was very easy to treat in the initial days. I think Naxar and all when we doing only Cetran or simple ampicillin or chloramphenicol was very effective in treating typhoid fever. But now it's not at all useful, and people are also very hesitant to use once the diagnosis is there. So there is a lot of resistance to ceprofloxacin also, and XDR typhoid has extensive drug-resistant typhoid fever. The treatment is azithromycin, and azithromycin is an effective treatment. But however, said azithromycin, as we all know, has been used extensively during the COVID period and all those that time, and it was proven to be very ineffective after soon after that. So then carbamazepines are another option for extensive drug-resistant typhoid. So clinicians should consider the patient's travel history while choosing the treatment. So typhoid prevention. So public health interventions like safe drinking water, improved sanitation, strict hand washing, adequate medical care, compulsory screening and vaccination of food handlers. Because in Kerala we are having that certification of food handlers, for which it is all compulsory. Avoid eating street foods, especially salad and cut fruits, which is not properly cleaned, and chronic carriers should be counseled for strict hygiene. And as you know that complications are there in 10 to 15% of hospitalized patients, and immunity following the infection is only partial, increasing AMR and recent outbreak of ceftriaxone resistance in Pakistan. Because even we are using ceftriaxone right and left as a safe antibiotic. Some there was some talk recently which I heard. This the patient is not ceftriaxone deficient, like for the symptoms, just for fever also. So now we are coming to typhoid vaccines. The first generation we had inactivated whole cell vaccine. The second generation we had the live oral polysaccharide vaccine. I think many of us might be remembering that we had the Typhoral capsules which we used to give, which didn't have long lasting immunity. Now we have the third generation VI conjugate vaccines, and in pipeline we have NTS and paratyphoid conjugate vaccines, which are not commercially available at present. So the typhoid conjugate vaccine, which is very effective, is licensed up to the age of 45 years. That is from 6 months to 45 years. It's 0.5 ml IM. Efficacy is 87%, zero efficacy of 85%, and a single dose of TCV from the age of 6 months onwards is recommended. Routine booster for TCV at 2 years is not recommended as of now. Earlier, there were some talks about giving booster doses because the seroconversion was quite high. So the available vaccines are TCV with TT adjuvant, TCV with the DT adjuvant, and TCV with CRM adjuvant, that is diphtheria adjuvant. In whom is TCV recommended apart from children 9 months to 18 years? So all the travelers to endemic areas, they can have this typhoid vaccine. Household contacts to a documented carrier case. school children, those living in dormitories and sharing the common toilets and bathrooms, those attending melas, yatras, and large gatherings, food handlers, microbiology lab workers, and all those who demand it. Finally, those who want to take can take it. So, what is the recent ACVIP recommendation regarding typhoid vaccines? A single dose of TCV is recommended at present. Age group is 6 months to 45 years. Preferably, age to start is around 9 months. IAP advises catch-up vaccination till 18 years of age. There is no scientific evidence regarding need of booster dose at present, particularly in endemic countries. Advice: 7 years follow-up data after the vaccine showed adequate antibody titers well above the cutoff values. So that is the reason we are not advising the booster doses. So there was a clinical trial with this was included in the action plan. That's why there was a clinical trial with a vaccine from Cadila, that is Zyvac TCV, in comparison with the Type R TCV, that's from Bharat Biotech. So immunogenicity caused by this seroconversion was fourfold rise in antibody titer post vaccination in both the cases. And secondary immunogenicity, you had the data was also high in both the cases. That's 55 to 56. Both there is no much difference. And safety results also, the number of adverse events were around 59%, and all the adverse events resolved completely during the study period. So the test group was 33.6 and the reference group was 43.8%. So to conclude, typhoid VI conjugate vaccine, the results of this single-blind multi-center clinical trial suggest that typhoid VI conjugate vaccine of Cadila Healthcare is not
frontal headache and myalgia for 6 days duration, and she had symptoms of breathlessness for 2 days. So on examination, this girl is toxic looking. She's having high temperature is 103 degrees. Pulse rate is also high, 102 per minute, and she is having tachypnea, that's 40 per minute is the respiratory rate, and saturation is also low, 88% in room air, and BP is 110 by 60. So definitely she is toxic looking with tachycardia, tachypnea, low saturation, and BP is at present okay. There was generalized macular non-itchy rash involving palms and soles. So what are the rashes we just the rash in palms and soles, what are the diseases we see? And for rashes in palms and soles, we should have a thinking of rickettsial disease in our mind. So on systemic examination, there was normal neurological examination, cardiovascular system was normal, but in the respiratory system, in the symptoms also we had breathlessness, and the child had fine crepitations in infrascapular and infraaxillary region. She had a soft liver papal 5 cm below right costal margin and soft spleen 1 centimeter below left costal margin. So just think over a toxic looking girl with tachycardia, tachypnea, low saturation, having hepatosplenomegaly, and with fine crepitations, respiratory symptoms. So what do we infer from this? So this is history and examination what we have. Coming to the investigation, this is the rash which is shown in the body, the macular rash, which is the typical is non-itchy rash. So all the allergic rashes are itchy, but it is non-itchy rash. So we do have here the CBC. Hemoglobin is 10.9, slightly low for the age, definitely. Platelet is 91,000. We need 1.5 lakhs and above. Here we have thrombocytopenia. And sodium is definitely low, 122 milliequivalents per liter. Potassium is normal. And in LFT, albumin is low, 2.8 grams. Serum bilirubin is little high, 2.8. And SGOT, SGPT are definitely higher than normal. PT-PTT is normal. So this is the investigations what we have. So just think over a toxic looking girl with tachypnea, tachycardia, low saturation, with cracks in the chest and with thrombocytopenia, with hyponatremia, with hyperbilirubinemia, hypoalbuminemia, and little bit of transaminitis, I can say. So the X-ray shows peribronchial thickening and bilateral perihilar haziness is there, especially in right paracardiac region, and atelectasis in left middle and lower and right lower also. So this is the rash what we found. This was seen on the left posterolateral aspect of a chest wall. This is the scar what was found on examination. Usually if it is one or two, they don't come telling us there is a rash. We need to look out for this scar in a child whenever we don't have any clues what exact fever this is. So what is the differentials and further plan of action at present? What do we have? So in the lab workup, definitely we, as one of you said, so do we go for Weil-Felix test or IgM for scrub typhus? So here is a question. How many want to go with Weil-Felix? Just raise your hands. How many of you want to go with IgM for scrub typhus? Yes, definitely. I don't think I need to go further. And IgM for scrub, as you all asked for it, it was reactive and confirmed by immunofluorescence assay. So on admission, she was initiated with IV doxycycline because she was toxic, and the infusion at 2.2 mg per kg was started, and fever definitely subsided by third day, and she was switched over to oral toxi and discharged by 5 days in a good condition. What we get when we start doxy at the right time, at the right on the examination, if we suspect rickettsial diseases. So it's very important to start the treatment at the right time to avoid any further complications. So coming to rickettsial diseases, this is the classification. We have spotted fever group, we have typhus group and others. In the typhus group, we have the scrub typhus, which is caused by Orantia sussugamushi, and the vector is the mite or the chiggers, what we say, and rodents are the reservoirs. Humans are accidental host because of the bite, but it's the disease of the rodents. So because of all these things, One Health is very important. We need to take care of the health of the animals and birds. We need to take care of the health of the humans and the environmental factors altogether. So here is the triad: environment, host and agent. We do have during rainy season, the conducive environment is in the amidst of rice fields, seashore. Host, as I said, it's rodents. Humans are accidental and dead-end host. Agent is Orantia sussugamushi. This is transmitted by infected mite. The organism is in the salivary gland, which is transferred to the human. So if we go to the epidemiology, it is there in almost all the states of the country except few, Gujarat and Madhya Pradesh. And in scrub typhus is all over. Indian tick typhus is found in Andhra and Telangana. So coming to the scar, it starts as a enlarging papule at the site of chigga bite, and often in the concealed moist areas of the body, like behind the ears, axilla, inguinal groin area, or under the and the moistness is there. And later it develops into a classical scar. It's not usually more than 1 centimeter, and there is a central necrotic black scab, and it is surrounded by a raised ring, and it is having a surrounding erythema, and usually it is non-itchy or painful. That is the reason child doesn't notice, and even the child doesn't complain to parents and even the doctors. So it is taken it as something the child has had some injury or something. They don't come with this complaint basically. We need to find out. But if it is there, it is definitely in different studies it has been shown that 7 to 70% of patients had a scar in the rickettsial disease. So this is in the scrotal area, in the groin, in the axilla where the scar is found. There is a red induration which enlarges, vesiculates, ruptures, and finally the scar. It takes almost 3 to 4 weeks to resolve. So probability is higher than 70 to 79%. It is probable rickettsial disease. It is in axillary fossa, inguinal region, scrotum, buttocks, and it's ulcer surrounded by red areola and is often covered by dark scab. So the most specific manifestation of scrub typhus is scar. So please look out for escar. They don't come with that complaint. That is one key message for this tropical disease. So this is the distribution. The maximum you see the distribution in genitals, inguinal region, followed by axilla, and then head and face and neck region. So coming to the second case here, here is a 16-year-old boy who presented to emergency with high-grade intermittent fever with rigors for 7 days. So he has crossed the first week, he's come after around 7 days. He has retroorbital headache for 7 days, diffuse abdominal pain from right iliac fossa to left iliac fossa. It's all over the abdomen, mostly remains undiagnosed. Thank you.
Use diagnostic test, the Rose Bengal test, then your tube agglutination and ELISA procedures are recommended. Then methods to differentiate IgM and IgG can distinguish between your acute and past infection. False positive reactions can occur and skin test reaction indicate past exposure, not recent infection. So this is a Rose Bengal test. This is a agglutination test, which you can see here, the clumps. Okay, so that are the agglutination reaction which has happened. That is your Rose Bengal test, which has 87% sensitivity and 100% specificity. So this is our standard tube agglutination test, which has a good specificity of about 95% to 100% respectively. So when do we suspect brucellosis? So brucellosis, any child with pyrexia of unknown origin, you will always keep in mind brucellosis. This usually comes with fever since more than 2 weeks on and off, usually not septic child. Then they can have, which we showed like a previous case, they can have arthralgia or arthritis, usually joints involved are your hip, knees and sacroiliac. Then they can come with organomegaly, they can have splenomegaly, hepatosplenomegaly. Then when clinically suspected, what happens, whenever you have fever, we start, take blood culture, we start with your ceftriaxone. Ceftriaxone is like treating for each fever, instead of antipyretic, ceftriaxone is given. So your kid does not respond to ceftriaxone, in a lighter way, you need to think about brucellosis. Then osteoarticular tuberculosis and brucellosis, they are very close differential diagnosis, this has to be kept in mind. So animal contacts and dairy products, basically they have contact with livestock, then consumption of raw milk. Treatment for child with brucellosis. So this has been divided: child more than 8 years, child less than 8 years. So child more than 8 years or adults, our treatment of choice is doxycycline. Usually we have monotherapy, dual therapy. Dual therapy is preferred. So doxycycline 400 mg orally twice daily. If you take mg per kg, little more than what Priya madam mentioned for your rickettsial fever. Here it is 4.4 mg per kg per day, but maximum of 200 mg. And gentamicin, which can be given up to 2 weeks. So this is the most effective and most superior therapy. So we have one more therapy which is used for your OPD based treatment, where we can combine with doxycycline and rifampicin. So doxycycline is given for 6 weeks and rifampicin is also given for 6 weeks. This is the most practical and commonly used regimen. So prim sulfamethoxazole cotrimoxazole combination, which can be given for 6 weeks along with rifampicin. That is also given for 6 weeks. So this is about the first case which you saw, a limping child. Diagnosis of brucellosis by your serology. Treatment with based on the age criteria. Though as madam said, now we use doxycycline less than 8 years or 4 years or 2 years. Life-threatening condition, it can be used, no problem. But here guidelines tells less than 8 years, cotrimoxazole is on par with doxycycline. So this child is a 5-year-old child. Again here, history is little different. So fever for 5 days. This is a sick-looking child. You have a pulse of 120, respiratory rate of 40, BP is hypotensive, 80 millimeter of mercury. So we have liver of 2 centimeters, spleen of 3 centimeters. We have hepatosplenomegaly. Here, when there is fever, sick-looking child, blood culture sent, antibiotic started. But after starting antibiotic, child has not responded. Even after day 7, has not responded to your antibiotics. So the clinician labeled it as your ceftriaxone resistant fever. Now they have done an ultrasound in this child. Echoic splenic infiltrate. So this is a very important marker. Whenever you get an ultrasound finding suggestion of hypoechoic splenic infarct, has been repeated in another center where your Brucella test is positive. So why has this happened? So here we have something known as Prozone effect. So what is this Prozone effect? See, whenever for a lab to detect your antigen antibody reaction test, there should be optimum antigen and optimum antibody. If the antibody titers are more, that antigen antibody levels will not be detected by the lab. So this is the effect which is called as Prozone effect, where inhibition of agglutinations at low dilutions due to excess of antibodies. So what has to be done here? This has to be serially diluted and has to be serum agglutination test as can be repeated. Less than 1 month, subacute, then they can have chronic. They can present as focal disease or a generalized disease. So this was about the second case. We have one more case here. A child, we have a 8-year-old child. Again, fever of more than 6 weeks duration and occasional pain abdomen for 6 weeks. So here, pain in the right shoulder, mild arthralgia, arthritis-like features, then history of decreased appetite and weight loss. Then this patient's father was a farmer by occupation and there was no other significant family history. So this is a ill-looking child, temperature of around 101, spleen is palpable, liver was just palpable, no lymphadenopathy and known signs of meningeal irritation. So low level of hemoglobin, HB of 8.7, total count of 6,900, differential counts normal, little bit of high ESR because of high fever, then your total and direct bilirubin are within normal limits. So HIV, HB negative, all the tests are negative here. Again here, one more case where there were hypoechoic 2 to 3 millimeter splenic infiltrate. So this is a splenic infiltrate which you can see here. So this we have discussed, like where all you get your microsplenic abscesses. So again, see, we most important is history taking. It is a skill and an art. In our hurry-burry, we just forget to take the history. We are into investigation. Now, whenever our PG calls, they don't tell history and examination. X-ray done, antibiotic started. There is no localization of thing, nothing. I think sometimes we myself have to be, we consultants have to be, I feel. So here there is consumption of raw buffalo milk that was told by the boy. So this child had this buffalo had a decreased milk production, subtle indication of thing in this buffalo. So this is again a child with brucellosis. So here child and brucella cap test. So in this case, from the splenic aspirate, plenty of pus cells has revealed and gram-negative Coccobacillus arranged in single spats and clumps. So blood culture, as we told, it is a slow growth. So we have to tell the microbiologist. So splenic aspirate on the 7th day grew brucellosis melitensis. On the 10th, on the blood culture, day 11, it grew same melitensis organism. So we have to remember it is a very slow growing organism. So what is the treatment for this child? Doxycycline, again we give around 4.4 to 5 mg per kg. Then streptomycin, 25 mg per kg once a day for 2 weeks is to be given. And here child became afebrile and discharged from hospital from day 10 after admission. On follow-up after 2 months, child gained weight, appetite, everything. The serum titers of your serum agglutination test decreased. Your 2-ME test also became negative. So ultrasound also was repeated. Your micro abscesses also disappeared, and this child responded to what treatment we had given. This study was done by published by our Mahesh Kore sir. He is a very famous pediatrician from Maharashtra. So splenic abscess due to Brucella melitensis, a rare pediatric complication. So I think there is one more case here. A 4-year-old child, fever on and off since 2 months. Child is having limping gait and hepatomegaly, which is 2 cm, which is a firm hepatomegaly. So here Brucella is confirmed. Now we are well versed with Brucella because we have seen in the first 2-3 cases where there is arthralgia, arthritis, we have to suspect when there is PU of more than 2 weeks duration. So here Brucella test is positive. Now we know, we have learned the treatment also. We have started with your cotrimoxazole and rifampicin. But what has happened here? See, after 2 days, child has gone to hypotensive shock. Now this child required Chaitra's, okay.
And this even the during Sunday, they are good attendance. What to time he can on health module committee faculty because I got a chance to present it. I forced to present this schedule. And so in the presentation. Okay. 12% with the fever since 3 days. That is not a toxic. Vomiting since 1 day, hepatomegaly, elevated liver cancer, thrombocytopenia, that is around 52,000. Leukocytosis, 27,400. Hemoglobin 4 gm per deciliter, ESR 20, normal creatinine. What are the DDs? Maybe infections. Infection may be septicemia, malaria, dengue, leptospira, recursive fever. Autoimmune disease may be the malignancy, HLHA. How to differentiate all these? Fever refers to thrombocytopenia. First, we have to hemoglobin. If it is high, then we suspect dengue. If hemoglobin is low, we suspect malaria. If high serum creatinine, that is suspect leptospira because it will alter the liver kidney function test. Leptospirosis. What are the signs? Fever, body pain. Body pain is mainly lower limb and lumbosacral regions. Thrombocytopenia will be the vomiting, dearranged liver enzymes, non-valeric renal fat. These are peculiar features of this leptospira. Meningitis and uveitis. Febrile illness caused by spiracetal leptospira. It is a zonal disease, mainly rats. But in America, dogs and wild animals, domestic also infected. Animal excrete leptospira in the urine. It is survives for 2 weeks. Infect human when mucous membrane or upper skin comes in contact. Pathology is releasing toxin, it will result capillary leak, then it will cause ischemia, lastly kidney failure and liver, multi-organ failure will last result. Then hypersensitivity UVT is also result. Epidemiology of leptospira. Area with high endemicity include the Caribbean islands, Central Islands, South America, Southeast Asia, Pacific Islands. In India, leptospira was first reported in Andaman Island 1930s. Subsequently, it has been reported from Orissa, Maharashtra, Karnataka, Tamil Nadu, and Kerala. Kerala and Kasaragod and Malabar area is very peculiar. This leptospira. Subsequently, it has been reported from Orissa, Maharashtra, and Karnataka, Tamil Nadu, Kerala already at all. And now leptospira is reported to occur every rainy season in area with flooding and poor sewage drainage. What are the serotypes? Over 7 pathogenic species of Leptospira that have been isolated, which have more than 250 serotypes. Of the common pathogenic Leptospira introgena is the commonest. Serospecific antibodies are protective lifelong. However, infection by other seros are still possibility. Other serotypes in India is Leptospira, Antamana, Leptocommona, Griptoxum, all of the fancy names you can remember easily. Asparagus, Javanica, Automanisa, and Canicolas. Pathophysiology. Incubation period is usually 2 to 20 days. Predilection for kidney and liver. Directly leptospira injury, acute tubular necrosis. Antigen antibody complex of in the immune phase, interstitial nephritis is a result. Polyuria is due to reduced expression of the sodium hydrogen exchanger 3, resulting in increased reabsorption of the sodium and fluid by the proximal tubule. In the liver, central lobar necrosis is the proliferation of the Kupffer cells. Leptospira toxin disturbs the endothelial lining of blood vessels, leading to capillary leak and hemorrhage. The clinical features in 10% of the individual, the disease lead to renal and hepatic dysfunction. With the hemorrhage also known as Graves' disease or ischemic atrial leptospirosis may be associated with multi-system organ dysfunction in the form of pulmonary, cardiac, and CNS systemic characteristics of this systemic disease. Clinical features. A common symptom include fever, headache, myalgia. Headache is the bitemporal and accompanied by retroorbital pain. Continual suppression is one of the hallmark of this disease. 10% of the patient may develop severe leptospirosis. Renal involvement is seen in all phases and renal failure ranges from 50% to 75%. Most of the patients have non-polyuric renal failure. Maybe present monophasic or biphasic. Classically described, biphasic leptospirosis as an acute septic phase, usually lasting up to 1 week. When leptospirosis organs are present in the blood, followed by a second immune-mediated phase that begins 1 to 3 days later, and it is less likely to be respond antimicrobial therapy. Clinical type of leptospira. Leptospira may be classified into, according to the clinical features, anti-ecteric leptospira and ecteric leptospira and severe leptospirosis. It is the anti-ecteric. It is the milder form of the disease. Patient have fever, myalgia, but will not have jaundice. Almost 90% of the patient have this type of illness. Ecteric leptospirosis. It is the severe form of the disease. It is characterized by jaundice and usually associated with the involvement of other organs also. About 5 to 10% of the patients have this type of manifestations. Severe leptospirosis. It is resulting in hemorrhage, acute renal failure, acute respiratory failure, multi-organ failures. Mainly that may be due to acute renal failure. In this, sometimes cardiac ECG is normal, but it is not ending cardiac failure. Laboratory abnormalities. What are the tests? Mild elevated liver transaminase, hypokalemia. It is due to renal tubular wastings. Hyponatremia will be the thrombocytopenia and elevated prothrombin times. White cell count may be normal, but there may be shift to left with neutrophilic predominance. ESR may be elevated. How to diagnosis? Early stage of the disease, leptospira may be isolated on culture. Culture of leptospira requires specialized medium. PCR detection in blood sample in the first week is more sensitive than culture. Serologic test, leptospirosis may be persist for several weeks after initial infections. What are the serological tests?
City Gold and Diamonds, Kerala and Karnataka. City Gold and Diamonds, Kerala and Karnataka, the glow of purity.
വീടായാലും ഇൻഡസ്ട്രിയിലായാലും ബിസിനസ് വിദ്യാഭ്യാസ സ്ഥാപനങ്ങളോ മതപരമായ സ്ഥാപനങ്ങളോ ആണെങ്കിലും വയറിംഗ് വർക്കുകൾ HT LT കണക്ഷൻ എന്നിവയ്ക്ക് ഗവൺമെന്റ് ലൈസൻസ്ഡ് ഇലക്ട്രിക്കൽ കോൺട്രാക്ടറായ പള്ളങ്ങോട് ഇലക്ട്രിക്കൽ വർക്സിനെ തന്നെ ഏൽപ്പിക്കണം. പണി കമ്മിറ്റ് ചെയ്ത സമയത്ത് തന്നെ തീർത്തു തരും. കൂടാതെ നിങ്ങളുടെ സ്ഥാപനത്തിൽ അനുമതിയില്ലാതെ ജനറേറ്റർ സ്ഥാപിച്ചിട്ടുണ്ടെങ്കിൽ പള്ളങ്ങോട് ഇലക്ട്രിക്കൽ വർക്സിനെ ഏൽപ്പിച്ചോളൂ. എല്ലാവിധ പേപ്പർ വർക്കുകൾ സഹിതം ഉത്തരവാദിത്തത്തോടെ തന്നെ വർക്ക് പൂർത്തിയാക്കാം. കോൺടാക്ട് ചെയ്യൂ 9496 200 200 9497 500 600.
City Gold, Gold and Diamonds, Kerala and Karnataka.
Venus Trading and Services, your trusted partner in Qatar. Looking for reliable services in Qatar? Welcome to Venus Trading and Services, your trusted partner near Al Said Bakery in Muntasa, Doha. Let us introduce our range of activities. At Venus Trading and Services, we offer certificates attestation in India and Qatar, legal translation in several languages, police clearance certificates, data flow and prometric, company formation, health card services. Our experienced team ensures smooth and hassle-free processes. Choose Venus Trading and Services as your trusted partner in Qatar. Contact us today, 55488910. Venus Trading and Services, near Al Said Bakery in Muntasa, Doha. Partner with Al Farha Tours and Service.